We'll go on to the other topic again. I think I'll share those slides. Sorry, which is the new development in the IOLMASTER 700. I'll just briefly talk about it. Oh, okay. Okay, can you see my screen now? Is it okay?
Yes.
Yeah, so this the IOLMASTER 700 now has a new update. So it comes with central topography. And the workflow, basically there is no change in workflow. So you can use the IOLMASTER as you are using it right now, but central topography is incorporated in the workflow. So you don't have to actually do topography with another topographer, especially for your premium IOLs and your toric IOLs, or even your regular biometry, and you can detect any visual relevant corneal asymmetries. And you can also get the central corneal shape information very easily. And there are various data transfers available. You can use the EQ mobile or the holiday consultant. So, as all of you all know, preoperative evaluation of a cataract patient should include corneal topography, regardless of the type of IOLs, but it's especially more important for toric and multifocal IOLs because any corneal irregularities in the central optical zone can reduce vision and the outcomes. So this IOLMASTER 700 now incorporates this central corneal topography without any changes in workflow. And it also provides the anterior and total axial power maps. So you can visually, just by a glance, detect any corneal irregularities. So this is the total power map. It's measured in the 3 mm. The pupil diameter has to be 3 millimeters, and the topography diameter is 4.8 mm, and the scale is in 0.5 diopter steps. So it helps you in your workflow and patient decision. After doing the biometry, you also get the central topography. Then you can discuss with the patient and decide about the type of IOL which is suitable for the patient, whether they are suitable for the toric IOL. If there are any central irregularities, then they may not be ideal. Like if you can pick up keratoconus or early ectasia, then they may not be ideal candidates for premium IOLs. So this is the information that you have without any extra effort or extra equipment. So the acquisition is quite easy, and you, as you acquire it, you along with your axial lengths and your K readings, you also get the keratometry and the topography. And you also have the traffic light signals there. So green tick means that the acquisition is quite good. And it takes less than 45 seconds for both eyes. You can get all the measurements. So of course, this is about telecentric keratometry. That means basically if the patient is moving the head still, you get very accurate K readings in the corneal curvature is measured in 18 spots. And an anterior surface model is constructed, keratometric index is applied, and you derive the anterior axial power maps. So you also have the swept source OCT. This is something which I had spoken about previously. So you also get the posterior surface model and the total axial power maps because you have the posterior surface also. There are several studies which were done by Doc Koch and Dr. Wang, and where they compared central topography with other Schlemflug topographies to see if it can pick up corneal conditions, 105 eyes. So they found that central topography provides similar overall shape and symmetries in majority of the cases. And this is the scaling with the IOLMASTER 700 central topography. So you have the range from 34 diopters to 54 diopters in 0.5 steps and 41 colors. So just by looking at it, you can see steep is red, normal is a mixture of green is the average normal. And this is a normal topography. If it's blue, it's a flatter cornea. And you can detect cases of regular or irregular astigmatism very easily by just looking at these maps. They were compared with the Galilei 4mm maps, and they had a very good agreement. So the excellent comparability for with the rule, against the rule, etc. These are just the conclusions of the study. So this is the new let me stop sharing this. So this is the new development in the IOLMASTER 700, and where you get corneal topography, which is very useful for post-refractive surgery and also to decide about premium IOLs. So with that, I would like to end my talk, and thank you very much for your attention. If there are any questions, a couple
Yes.